severe toxicity, I should say. And also the cost of ipilimumab at that dose and regimen was close to $1.5 million for one patient's course. So this was actually published soon after I gave my talk at this conference last year. So this was nivolumab versus ipilimumab comparison. And again, similar to the metastatic setting, you can see nivolumab curve does better than the ipilimumab curve. There was another 10-13% benefit in outcomes over ipilimumab, and you can imagine the placebo curve, another 10% down or so. So in the adjuvant setting, nivolumab can probably add 20-30% benefit in this patient population if you were to extrapolate the two trials together. And the benefit was seen in most of the subgroups. Again, similar to the metastatic setting, the toxicity with nivolumab was much more favorable, 14% rate of grade 3 or higher as compared to 46% with ipi. So again, more efficacious, less toxic. In my mind, that's a no-brainer. We should not be using high-dose ipi for adjuvant immunotherapy of melanoma anymore. And nivolumab has been FDA approved and should be considered the standard of care. Or I should say PD-1 monotherapy should be considered the standard of care. Right around the same time, there was this other trial published as well, which was looking at BRAF/MEK inhibitors in the adjuvant setting. These agents were given for a year in patients who had BRAF mutant melanoma, again, high-risk stage 3B, 3C patients. And you can see this was a placebo-controlled trial. You can see big separation in the curves. So again, not a surprise. These agents are really active, and they can make a difference. This translated into some overall survival benefit. The trial actually had a very rigorous criteria for statistical significance, and even though the p-value is 0.006, it did not meet the pre-specified p-value, which was 0.000019. I don't really understand it, but you can see there is some benefit in overall survival as well, which I think we still need to, the data still needs to mature a little bit more. Just a few months prior, another study was published, which is using pembrolizumab against placebo, and again, not surprising, patients who are on the pembrolizumab arm are doing better as compared to placebo. So we have, multiple positive trials in adjuvant therapy, and the question is, what should we do in clinic? And I'll share my opinion. So obviously for BRAF wild-type patients, PD-1 monotherapy is the most appropriate at this time. It has better efficacy and lower toxicity than high-dose ipi. And BRAF inhibitors are obviously not applicable to this group. But the real question is, for BRAF mutant patients, should we use anti-PD-1 monotherapy, or should we use dabrafenib, trametinib? I don't think we have a definite answer on that, but I'll share my thoughts. So if we look at the efficacy profile, again, comparing across trial, which is not valid, the outcomes seem to be quite equivalent if you just look at the recurrence-free survival and try to compare it to the placebo. So I think you get similar benefit, but in my mind, if you look at the toxicity data, the toxicity of nivolumab in grade 3 or higher was only around 9%, and with the dabrafenib, trametinib, 40%. So when we discuss this data with the patients, most patients are choosing nivolumab at this time. But I think in certain situations where patients have a higher risk of developing an autoimmune condition, I think dabrafenib, trametinib will probably be a reasonable and preferred alternative in those situations. And last but not the least, those patients with high-risk stage 2 who were ignored in all the previous trials, they're also finally getting some attention. There is a clinical trial of pembrolizumab versus placebo in this group as well, and we will be benefit in progression-free survival, but we can see the overall survival benefit was not there. It was, it led to considerable toxicity. The patients who were getting it were miserable. The physicians who were prescribing it were depressed as well.